her illness. Her chart also says that patient was cooperative up to the time she passed away. So here's what happened. She was admitted by her husband, my grandfather, who wrote a note to the institution saying that maybe they could straighten her out. During her stay there, my grandfather asked multiple times about coming to visit. He was told that she was not in any condition to receive visitors, although during that same time, her medical chart states that she got along with others and she was doing well. One of my grandfather's letters to the institution read almost like an apology. It began with, "I hope you will pardon for my actions, but I want to ask of you a favor. I realize that it is not any part of my duty." Well, it was a part of his duty and responsibility to check on his wife. Then he asked that the director not be impatient with him. Racism influenced what happened to my grandmother, even from the time of her birth. Just think, she was born in 1898, and during that time, there were 123 reported lynchings of Black people. And by the time she was 2, there were 224 reported lynchings. And those are just the ones that were reported. During 1935 through 1940, we had the Tuskegee syphilis experiment that was perpetrated on over 600 Black men. At that time, in 1940, when she passed, 1/2 of Black people were out of work. Just think, in 1935 to 1940, Jim Crow laws were alive and well. Health services to Black people were influenced by slavery, dehumanization of Blacks, segregation, the pursuit of civil rights, and again, racism. The tragedy that happened to my grandmother affected my family. My father and uncle never knew their mother. They lived with their father's brother and wife, who referred to them as their foster children. And their grandmother even referred to the grandchildren as foster grandchildren. They grew up with the stigma of not knowing what really happened to their mother. And they carried this to their graves. Back then, you were looked at as being different. Maybe something was wrong with you if you didn't have a real mother, a father. My uncle stuttered, and he was prevented from attending school because of this. He was treated more like a work hand than a son. He was not allowed to even learn how to write his name. So in saying all that, what is needed now? When you think of what happened back then, the dehumanization, you know that there was absolutely no training for medical professionals. You know that racism impacted everything. Black people were seen as being 3/5 human. Today, even today, many people look at our race as being inhuman. That we're stronger, that we're not affected by pain, and we're not affected by things that other people are affected by. No one should die of medical professional neglect. Medical professionals should have training on cultural sensitivity and the historical implications of medical neglect. Education is key. Individuals who are going into any helping profession should be fully vetted to assess their character and intention on behalf of the population that they're going to serve. Experiential educational opportunities should be developed so that students can walk in the other person's shoes that they're taking care of. Work environment should reflect the diversity of those who are served. We've come a long way, however, we have a long way to go. If we work together, we can succeed in a humanistic fashion that supports everyone's physical and mental health, regardless of their race or the color of their skin. Thanks again for this opportunity.
Wow, thank you so much, Dr. Campbell. Thank you for starting this off this evening, for that profound story, for sharing your family's history with us, and for your call to action at the end there, which certainly is going to inform the rest of our discussion this evening. It is my pleasure now to introduce our moderator for our discussion this evening, Bailey Loosemore. Bailey is the Changing Communities reporter with the Courier-Journal. Bailey has worn many hats since joining the Courier-Journal in 2013, from neighborhoods reporter to food show host. She is currently focused on covering people and issues that shape our community, including housing shortages and racial equity. She is a two-time Pulitzer Prize finalist and an aspiring Kentucky State Fair winner. Please welcome Bailey Loosemore.
Hello, thank you so much for having me. And it is my pleasure to introduce our panelists for the evening, who I'm very excited for the conversation we're about to have. So we're going to start with Nicole Ford. If you want to turn on your camera as we announce you. Hi, Nicole. Nicole Ford is a PhD candidate in the School of Public Health and Information Sciences in the Department of Health Promotion and Behavioral Sciences at the University of Louisville. She is a graduate research assistant at the Office of the Executive VP for Research and Innovation and the Center for Social Justice Youth Development Research. Nicole's dissertation will focus on using critical race theory and ecological systems theory to explore Black students' mental health and the occurrence of racially traumatic events. Nicole received her bachelor's and master's degree from Texas A&M University in health and health education. She also holds a certificate in prevention science and is certified in youth mental health first aid. Thank you, Nicole, for being here. Next, we've got Robin Harrington. All of these people have very lengthy bios because they've all done such great things. So I'm excited to share them. So Robin Harrington currently works as an assistant professor / program chair for the Human Services program at Ivy Tech Community College of Indiana, Sellersburg campus. She is a native of Louisville, Kentucky, and is a graduate of the University of Louisville Kent School of Social Work, receiving a Master of Science in Social Work and completing 12 graduate hours in Pan-African Studies. She completed a portion of her studies at Jefferson Community and Technical College and successfully transferred to Northern Kentucky University, where she completed a bachelor's degree in organizational leadership and areas of concentration in women, gender studies, and communication. Currently, she works as a social work educator, clinical social worker, mental health therapist, and community advocate in the greater Louisville and Southern Indiana region. As a supervised clinical social worker, she provides mental health services to underrepresented populations that have limited access to quality mental health services. She is currently a member of Black Lives Matter Louisville Healing Team. Supporting future Black human service professionals is an important part of her job as a social work educator and advocate. Robin loves to serve her local community and provides consulting and support to several local nonprofits. She serves as a board member of the following organizations: Play Cousins Collective, West Louisville Mass and Science Project, and REACT. Thank you for being here. We have Dr. Brandy Kelly Pryor next. Dr. Brandy Kelly Pryor is a hope enthusiast, an intersectionality fan, and a scholar activist. As a community builder and visionary strategist, she has worked domestically and abroad to impact social change in various settings. Her work focuses on the intersections of health equity, policy development, and social impact of hope. Through her consulting work with BKP Strategies, Brandy developed health equity strategies for grassroots organizations, municipal governments, and Fortune 500 companies. Whether integrating racial equity into municipal comprehensive plans or examining social justice youth development principles in rural communities, her practice of storytelling and narrative building advances equity by celebrating and amplifying the dynamic and complex stories, spaces, and places of the lived experience. Thank you for being here as well. And finally, we have Desmond Stewart. last but not least, right? Desmond is a native of West Louisville. He earned his Bachelor of Science in Biochemistry from Xavier University of Louisiana and his PhD in Pharmacology and Toxicology from the University of Louisville School of Medicine. He is currently a fourth-year medical student at U of L and is pursuing a career in cardio oncology. So, all very impressive. Of course, I just shared a little bit about yourself, but for our first question, can each of you share a little bit about why you got into healthcare and what you currently do? Let's start with Nicole Ford.
Hello. So healthcare, I'm more so into mental health care. Of course, I am in the School of Public Health, and it's really been a journey to really be a part of the conversation that public health does belong in the conversations when it's talking about mental health. And so that's why, that's kind of how I identify right now. Recently, I did a study with Dr. Asha Brown at U of L. It was a community-driven study with Play Cousins Collective, and we were able to explore Black mothers' experiences navigating social services in West Louisville. So right now, that's kind of the lens that I can speak of during this panel.
Thank you so much. Ms. Harrington, would you like to go next?
Hi. So currently my work right now regarding healthcare, like Nicole, it is in mental health. And so I provide at least about 20 hours a week to total life counseling and consulting as a mental health therapist. And I also previously worked at, Our Lady of Peace, U of L Peace Hospital for 3 years. So having an understanding of the community mental health lens and how that intersects with communities of color is really important. It's another lens that I use as I'm working with my clients currently.
Thank you so much. Dr. Pryor?
Good evening. You know, it's a really, I think it's a part of the actual fabric of who I am. Just as Dr. Campbell was talking about the stories that helped to really shape her family, that has been a part of my my life story in terms of how the healthcare community has harmed as well as been a support at times. And so it started for me very young in terms of thinking about sickle cell and how that had impacted my family personally, and the way that my uncle was just able to also become a cardiologist and really work through that pain management. But for me personally, it really was the AIDS crisis in the early 2000s. And I was really involved in global public health. That's where I started my career. And we were having conversations very early on in that crisis about, especially from an international standpoint, about how education, how health, how housing really was impacting the global AIDS pandemic that was happening. And so that was my entry point, and I have been here ever since.
Wow, thank you for sharing that. Mr. Stewart, would you like to finish us out?
Yeah. My original decision to pursue a career in medicine was really born out of my kind of personal exposure to the healthcare system as a child. I wasn't like the sickest kid by any stretch of the imagination, but I wasn't the healthiest either. So by the time I was 18, I had a cardiologist, a neurologist, an ophthalmologist. Just those experiences really opened me up to all the different possibilities in medicine. And then my decision to pursue internal medicine specifically was really driven kind of by coming back home to Louisville and the shock that people would have when they found out that I was from West Louisville and a medical student at U of L. It's just not a thing that happens, and that that conversation really helped to kind of break down some walls between me and the patients that I had that looked like me and were from the same neighborhood as I was.
That's great. And I hope we can talk later about how to reach that point where that's not such a shock to people. Maybe we can get into some solutions for that later. But the next question we have is for Dr. Pryor, but of course, it can be open to anyone, because I think this is a subject that a lot of you probably have expertise on. But Dr. Pryor, you previously led Louisville Center for Health Equity, which has produced reports on root causes of health inequities. Can you please explain how health is connected to to societal systems and how racial inequities arise?
Yeah, that's it's a question we've been answering and talking about for a very long time here in Louisville. So it was amazing to be a part of that legacy that was built over 15 years ago. So in 2006, the Center for Health Equity started, and Dr. Adewale Troutman, who led the Louisville Metro Public Health Department and also led the American Public Health Association, was really instrumental in bringing the concept of social determinants of health to a national conversation. And not only was it a national conversation, but we were having that conversation more intentionally here in Louisville. So for anyone who is from Louisville, I think about all of the ways in which we need to be proud of Louisville's legacy, thinking about tonight and the Ali Center being able to host this. And, Muhammad Ali talking about race and racism at a time that was really impacting the mental, the social, and the well-being of communities around the world, and the reasons in why he did his fight the way he did against in the US, excuse me. So in terms of talking about the social determinants of health, or how racial inequities are connected to that, the Center for Health Equity report first came out in 2011, 2012, another iteration in 2014, and then the third iteration in 2017. I really encourage everyone, if you have not seen it, please, please, please go to healthequityreport.com. I have heard that the next one is on its way. So I encourage you to check out the Center for Health Equity led by T. Gonzalez as well. In that report, it details, and it is so critical for us here tonight to know that ahistorical is not a thing, right? History matters. We heard Dr. Campbell talk about, it was written into the Constitution that African Americans, Black people born in this country, Black people who were actually enslaved in this country, were written in as not fully human. So when we talk about the health of our communities, we cannot separate from the fact that race was constructed in this country for an economic purpose, and race has continued to dehumanize people of color, whether they are indigenous to this country, or whether they were enslaved in this country, or whether they were born in this country as an enslaved person. And so it is with that history that we cannot separate the fact that we've embodied these truths in our bodies. Our bodies are holding the legacy of this history. And so that means that although race is not biological, we see these patterns that happen along these socially constructed lines. So I'll talk more about that.
Thank you so much. No, that was a very good overview. I guess if anyone would like to add anything to what Dr. Pryor said, please feel free.
I would just like to add, I was at the health department in 2007 when Dr. Troutman was there. And it was amazing to be a part of the work that he was doing and not really understanding at the level then from a public health what all this stuff he was talking about. And it was a wonderful opportunity being an employee and being involved. And one of the things that really struck me was when we went out into the community doing the community health screenings. And this was an opportunity where we were taking everything, all the data, all the theory that we talked about. Now we're putting it into the community to do health screenings to see what was impacting people living in different neighborhoods. And what we know, some of these neighborhoods are frontline communities to Rubber Town, pollution and environmental racism and all these different things that occur. But that, for me, back in I believe it was 2008 or 7 when we did that. I can't remember. I just remember we were intense doing a lot of work. But it was so pronounced to to see what he was talking about with these social determinants. And then we're looking at folks in the Chickasaw neighborhood, the Shawnee neighborhood, food deserts, and all these things, and seeing how all these things play in. Fast forward to where we're at now into 2022, still having these same conversations, still seeing, what are the ways we can still address some of these things, but still seeing the gaps. And from a mental health lens, looking at how does all these things impact the mental health. And when we're looking at physical health, like I said, I'm nowhere that, internal medicine, but I do have enough common sense to know that if our physical is not on track, then our mental is not going to be on track. And so there's a lot of things that we have to look at how it's all connected. So I encourage everyone to go out and look at those documents at the Center for Health Equity, because that's really what shapes, that's the evidence that we can use as practitioners, community leaders, to kind of see and track from when the first report came out in 2011 up to the 2017 to what is about to come out, how we can really make some noise and take some actions.
And just for those who are listening, as Robin was talking, Bailey, I was thinking, just to give a little bit more background to that language around social determinants of health. So when we're talking about social determinants, we're talking about housing, grocery stores, education, all of what we call at the center and what is called in public health as the root causes. So the imagery of the tree that was used in the 2017 report, just really that analogy is so powerful for me to think about. The leaves of the tree are our health outcomes in community. So we can think about COVID-19, we can think about HIV, we can think about mental health in community. That's where we see the leaves of our tree. And is it thriving or is it withering? Now we know if a tree is withering and it is in springtime, that the roots, something is happening with the roots of that tree, right? And so the roots of the tree would be the education, the health, the housing. Now, when we're talking about how does racism impact those social determinants, those same things that are neutral in community, I talk about them as neutral in community. We all either have access or don't have access. It's not necessarily those things that are causing the health inequities, but it is the way in which those roots, to extend my analogy here, the way that those roots are planted in the soil. And so the soil of the tree is what I would call the structural determinants. And the structural determinants are racism, our sexism, it's our economic oppression that happens in communities. And so as Robin is talking, we see that communities in Louisville have been constructed not only along class lines, but we are a very racially divided community, as many communities around the country have been, largely because of those policies that were put into place, not just in the construction of race in the mid 17th century or in the idealization that Black people in this country were 3/5 human, but all the way through our 20th century, where we see that housing policies said where you could and where you could not live. And that is impacting 2022 in terms of where a Panera might go and deliver their particular goods and services, or who might have access to internet infrastructure in their community, so that when school closes, then who is struggling to be able to work at home or to have access at home versus who is not. And so when we're talking about the full connection, what the Center for Health Equity has done for all of these many years, although we were having these same data conversations about life expectancy and how individuals who were Indigenous to this country, immigrants to this country, and Black individuals in this country, how they were dying earlier. We were having those conversations in the 1800s by doctors, Black doctors who had to leave the country to go and study elsewhere. They were having these conversations. So it's not a new conversation. I think we need to become more intentional about how are we getting to the answers of what are we going to do about it.
Mm-hmm.
Thank you so much for sharing that. Yes, I know the tree metaphor was very helpful to me personally when I saw that report, because I think this has maybe been mentioned in the reports or elsewhere, before that, a lot of people like to maybe focus on personal choices and biology and things like that. So this is kind of taking a broader look at of course, how society is affecting health and how then racism is affecting the systems that affect health. So it's thank you for sharing that so eloquently. Moving on to the next question, and this is open to anyone. The coronavirus pandemic drew attention to inequities in the healthcare system. In your field, what do you see as the main issues causing racial disparities? If we want to start with Nicole Ford or Desmond, if either of you would like to start.
Sure. Yeah, I actually thought about this question quite a bit. I think that some of the racial disparity that we saw in the pandemic can really be explained by kind of socioeconomic. So, you're much more likely to be poor in this country if you are Black. I think that's pretty well understood just based on systemic problems that we have here, right? And I really think that poverty really begets some of the lack of access to healthcare. The West End really kind of, if you look at two zip codes in the West End, 40212 and 40211, I think it really kind of highlights how poverty is maybe the root cause and not necessarily race itself. So 40211 is like 94% Black. The median income is about $23,000 for a household compared to about $54,000 for the city average. 40212, because of Portland, is about 60% Black, so about 34% white. And the median income there is about $27,000. And the rates of death there between those two zip codes during this pandemic have been roughly equal, at least in the 2021 data that I could find. If it were just race, if it were something intrinsic to being Black that led to the increased mortality, then the rate of death in 40212 should have been significantly lower than 40211, right? Because there's 30% white population there that shouldn't be affected. But those poor white people in that neighborhood were also kind of disproportionately affected because they live in the same socioeconomic situation as the rest of the West End that is predominantly Black, poor, unable to afford healthcare in this exorbitantly expensive system that we have, living in a community that doesn't have community health clinics. You have to leave your neighborhood to go to the doctor in the first place. So I think that, yes, the poverty that is disproportionately placed on Black people in this country really underlies a lot of the health disparities that we see.
Yes, I can echo a lot of those sentiments, but just looking at the transcripts in the study I mentioned that we partnered with Play Cousins and the mother's experiences, whether they were perinatal or looking at their pediatricians or their own personal primary care physician, it just was so disheartening the way that they were just disregarded. Many conversations where race came into play about their social service provider, and the fact that they had to really advocate for their children or their unborn baby of how they wanted their birth plan just to get on the table. And they completely switched up the birth plan. And the mother's asking what's going on. And they said, no, just do this. We're not going to tell you. And then when the baby comes out, the mother explicitly says, I want to breastfeed. And then they go ahead and give the baby formula and say, you can't see it. So it is that level of not necessarily even education, but being aware. That's why we're seeing so many Black doulas and midwives that have this experience just in the birth itself. So it's like, even if you don't, I need to have an advocate because I already know that the medical system is not going to advocate for me. They're going to look at me like, this is my job. Your body's basically mine while you're in my care. So whatever you say, it doesn't matter because I'm the one that's in charge. And so we're really having to counter all those things that we already know that's going to happen, when it shouldn't be like that, right? You're going to your primary care physician, you're trying to have this conversation, but when they see that you're Black, let alone if you're young, that came a lot. If you're a young mother, they already assume you don't know anything. And so many things attribute to disparities, but it really is just the blatant disregard that they see already when you're Black. And then you have to talk yourself up to show, like, I know some things, which is ridiculous. But definitely it's this power structure and power dynamic where they're seeing themselves as up here, everybody's down here, especially when you're dealing with Black patients. So a lot of things, and that's why I'm pretty sure we'll get into later, why there has to be so many trainings amongst medical professionals. And the fact that you do not practice cultural humility. There is no such thing as cultural competence, because you'll never know, but it's your job to have empathy and to listen.
Thank you so much for sharing that. I imagine that weighs a lot on you mentally too, you know, to go through experiences like that, which kind of gets into the next question we had, which was many Black people in our community are still healing after witnessing the police killings of George Floyd and Breonna Taylor, as well as experiencing racism in their everyday lives. How does racism affect mental health, and why is it important to address racial trauma? Seems like maybe Robin would like to speak first.
Thank you. I would say, going back to the past 2 years, and working with clients, and not just clients, just even just working with Black folks during the past 2 years. And I'm gonna briefly sum up two things. Working in higher education and what it's been like for Black people working in predominantly white institutions with Ahmaud Arbery, George Floyd, and Breonna Taylor, and then what it looks like just for our community folks. The mental health from your professionals working in higher ed and trying to navigate the systems that we work within during these highly racialized times has been very difficult. And again, it's one of those things where people felt a lot more pressure, people coming to you. I know I definitely had a breakdown in one of our meetings at work, and it was like, hey, I'm not the expert. I'm struggling over here at this point. And so that was a lot that I seen 2020, 2021, with people just trying to really understand. Some people in shock. You had a lot of different responses from Black professionals. I can't believe this is happening, and all these different things. So I think from a therapeutic standpoint, in working with people was, having a space, someone that looks like you, someone is saying, you're not crazy. One of the things that I would like to say, whether you are, regardless of where you work in, what it looks like, but when you have experienced something on the job and for a fact you didn't get this job because of the way you look, and you're the first one there, you're putting in 15, 25% more than everybody else, you are highly aware of the good old girl and good old boy clubs and all those things. And then to be told, no, that's not what happened. No, that's not what happens. So then we have something that I like to say, you may not have a diagnosis of psychosis, but your environment and constantly being poked and jabbed and being told that you're delusional when you're not delusional will create an aspect of psychosis. Mm-hmm. One half of psychosis, as we know, is hallucinations, the auditory, the visual, and then it's the delusional thinking. So I use that because that's what I see a lot of times. I know I'm not crazy. I know I'm not crazy. Having a clinician of color to say, after you listen to the whole story and you know how the game goes, no, brother, no, sister, you're not crazy. And so it's very validating. So that's one of the things I would say over the past 2 years is the increase of Black clinicians. being intentional. A lot of my colleagues have been very intentional in, getting the necessary certifications, working together, not against each other, but working together to really promote, because the need is so great. But the main thing is allowing space for people, because it was a grief and a loss to see what we've seen with George Floyd. And we had to process that. Then we had to process things that some men that I know who've experienced encounters with the police, they're being re-traumatized. So there was so many different things coming out that still come out that for clinicians, we have to take all this into consideration. We have to be very familiar when we talk about racial trauma. We have to be intentional to let people tell their stories and help build that, empower and resistance, and help people build that strong identity of self and love, to help them know it's not you. No, you're not crazy. No, you are not imagining this. It is what it is, but this is how we're going to deal with it.
Thank you
I
so
would like
much.
to add to that, if you don't mind, just a little bit, but that's
Yes,
kind of
please.
my spiel right now, is advocating for caring about the mental health of Black students, specifically when they're on PWI campuses. Me coming from Dallas, Texas, moved here in August 2019, and the major traumatic event of Breonna Taylor dying and being murdered by police was extremely traumatic. And it really made me think about all the trauma that's been happening, regardless of just being on a PWI campus. And then when these events are occurring so often, unfortunately, mental health services aren't equipped to prepare for that influx of all these Black students needing care. And as Dr. Harrington was saying, there's not mental health professionals that can take on all of this, no matter what the training is. And so really looking at that period of, yes, you have this height of services where they're saying, okay, we're going to have these Black support groups and mental health, but then they kind of die off as the weeks go. But in the literature, it's showing that the first 1 to even 2 months, even 3 months are so crucial after a traumatic event. And let it be someone else that dies, that adds another 14 days. And so definitely advocating for those services that aren't just, reactive, but proactive in the sense, and they're not going away. People are still checking up on you, and even looking at how systems work within the university, right? Though the University of U of L, they were being very supportive, it was still kind of just up to the professors. Are they going to give you extra time to complete your coursework? Can you take mental health days? There wasn't a set policy for those type of things. So thinking about that, even within the university culture, and how are we caring for our Black students when these racially traumatic events occur?
Bailey, I wanted to continue. I think this is really a critical conversation when we're talking about the structural violence that happens in communities. And so you're asking about, and our conversation is really dealing in terms of how do we care internally? And that is so important. And how do we have greater numbers of clinicians? That is so important. And I always center things in terms of the individual is embedded in communities. So what the individual and what those interpersonal relationships around that individual can do are definitely important. I study hope. I talk about the stories that we have that create those opportunities for hope. But I think it is also a critical conversation for us to expand, to think about the structural violence that has created this inequity in the mental health, or the post-racial trauma that we actually have in this country. And all of us, I think we are generally centering this from the experience of a marginalized person who has experienced the trauma, and decentering that conversation about whiteness. And when we aren't addressing what is whiteness, who is whiteness, how has this been designed and defined in a way, so when we talk about poverty, poor white people fare better in this country in every aspect than poor people of color, poor Black people especially. And so the Brookings Institution has done these multiple dimensions of poverty, and we see that the dimensions add upon each other, they stack upon each other structurally when you are a person of color in this country. When we talk about prenatal and postnatal care, the maternal mortality rate is 2.5 times higher for Black women. And that is not based off of poverty. That is not based off of education. That is not based off of having the status of a partner. Generally, the higher you are in your status of education, the higher you are in your economic status, the greater the likelihood for maternal and infant mortality for Black women. And when we think about the wealth gap as 10 times greater, how did that wealth gap get that way? You know, when we think about the ways in which labor was used in this country and how that built the wealth of families, and that in and of itself can create a sense of security, a sense of being able to move past the traumas that you have in your life. And so we cannot decenter again, and I will continue because the structures, if we are going to move, like I said, we've been having this conversation since the 1800s. So if we're gonna move, we've gotta move past the individual and the clinicians coming around the individual to solve the problem. We need to start talking about the moral and the social capital in this country and the institutions, and having those conversations of why is the trauma being created to begin with.
I don't want to spend too much time on the one question, but I do want to follow up on what Dr. Pryor said about mortality or maternal fetal mortality in Black women compared to the rest of the nation. If I remember correctly, there was a study that was done comparing African-American women and then African women who immigrated to the US. And African women who had had multiple births in Africa without complication moved to America and then started experiencing the same complications that African-American women experience here. So there is something kind of intrinsic to the Black experience here. I mean, we've begun to understand that stress influences gene expression and can definitely influence not just gene expression in a person, but those changes can be passed down generationally. So yeah, there definitely is some intrinsic problem with being Black in America that worsens our outcomes relative to other people. And that's, I thought it was fascinating, just that moving to this country from another country can result in you dying more likely than other people.
And not wrong with being Black, but racism against Black people, right? Because we love being Black.
Right, exactly, yes, yeah, precisely, sorry.
An important distinction for sure. So I kind of want to skip ahead a little bit to solutions, because I know that's been coming up a lot, and it seems to be twofold. One is having more Black people and people of color involved in these these fields, and being aware of, and maybe people in the field being more aware of issues and being more considerate, I guess, to Black people and people of color. But it's also fixing these systems that are causing the health issues or contributing to them as well. So I guess, what practices and policies still need to be changed to, make these equitable outcomes reality? Start with Dr. Pryor.
I was like, I don't want to start first if there is some, but I really do want to just touch on the fact that these policies have been created and compound over time, right? So we need to start there. One of the things that we do in BKP strategies is racial equity impact assessments of policies, and really doing equity audits and where can we start? And so I think some of the questions that we need to ask, instead of which policies, are basically how are we reflexive around the status quo, and how is that status quo continuing? And so there's lots of policies that compound on one another. I think generally we can say that there are many of our race-based policies have been overturned, but the ways in which they still operate, obviously in practice, how do we start to look at what I tell my students? we need to really consider the small p policies, like what is the practice and the procedure of playing these out in community. Another area that I think is really critical in this conversation is participatory governance. So what are ways in which communities, it is such a critical aspect that those who are most challenged by the issue or the problem, that they are involved and have a seat at the table. And that includes having young people, these intergenerational conversations that need to happen, and not in a token way. I think that is really critical and important. And oftentimes we see movements that are happening in the city or in the state, and we get, one or two faces of that represent an identity. And as we've heard even recently by our those who govern this state, in terms of thinking there is a norm in terms of who is an American and who is not. And there is a norm in terms of who is considered part of the citizenry and who is not. And so we need to start to really be reflexive about those conversations and say, who's sitting at this table, and how, from your perspective, would we start to change some of these policies? And I think generally we've got systems and structures that were created under the guise of our race-based and class-based system that are still operating in that same framework, but we've done away with that system. And so they haven't done away with the ways in which, and we can think about even how policing has come to be in this country. What is the history behind that? And if we understand the history behind that, then we can start to understand some of the practices and policies that are exacerbated today.
Thank you. I know, I think, Desmond, you brought this up a little bit as well, especially from, a medical school perspective. I guess, what would you like to see change to address some of these issues?
More Black people in medical school, honestly. So I went to Xavier of Louisiana. It's the #1 producer of Black medical students, and that was not by mistake. They, decades ago, created a curriculum that was designed to get Black people into medical school. When they started the program, 4% of physicians in America were Black. And while they were successful at making themselves #1 at producing Black medical students, 4% of physicians in America are Black decades and decades later. So I think increasing diversity, increasing representation in medicine is absolutely critical, not just because you need Black voices there to advocate for Black people, but Black patients have a more holistic and effective experience when they have physicians who look like them. That's not just Black people, that's people in general. They did a study, a double-blind study, where they took physicians and paired them with patients that were the same race and different race. And when the races of the patient and the physician were congruent, the physician was much more successful at getting the patient to enroll in screenings for like diabetes, hypertension, what have you, just kind of basic screenings. But the interesting thing that I really found in that study was that not only that, the physician's notes were different when they were writing about someone that was the same race as them. So like the white doctor with the Black patient was just very clinical, just about the clinical things, and their blood pressure is this, and they want to do this, they don't want to do that. The Black doctors would write like, oh, they have a kid in elementary school, they're excited about this basketball game. They really took the time to understand their patient as a person. And no one's going to care about how much you know until they know how much you care about them. So giving people healthcare providers that look like them, that they can relate to, is definitely going to help address some of the disparity. And also we need to just do away with kind of race-based medicine in general. That is kind of happening. The one that really kind of sticks around right now is GFR, which is a measure of like kidney function. In the electronic health record, there is a GFR for African Americans and a GFR for everyone else, because of this old idea that Black people had just a different baseline than the rest, and not just like, you know, people of African descent, African Americans specifically, compared to literally the rest of the planet. And now we're starting to do away with it because everyone realized that's just completely ridiculous. But that persisted for decades. And it led to worse outcomes when it comes to kidney disease for Black people, just based on a myth that was just accepted as fact and perpetuated.
To Desmond's point, and Desmond, I know this is live stream, everybody's going to see this, but when for you to be a cardiology student and someone who has a genetic heart condition, when I heard that, I mean, I just got so excited, and I was like, hold on, my heart rate can't go up too much. But if it does, it's for a good reason. But I wanted to share that because even as a professional, and even what we're talking about, just knowing that I'm looking at someone like, oh my gosh, when is he gonna graduate? I'm gonna have to remember this name because I'm adding this to my contacts. It really has made me excited because, just as a clinician, going through working with some of my clients, and when they come with not just with mental health, but then they're presenting with heart conditions and kidney and all these other things. Taking that holistic approach is important, but I can only go so far. And what saddens me is that I'm like, clients are like, oh, I'm so great that I'm working with you, a Black therapist, and you get it, you understand. And it's not only that, you look like this person, but you can relate, just simple things as how we may call each other miss or sis or all these different things where you're building that rapport and really showing that compassion and empathy. And so I often hear that a lot of times with my clients where one thing could be going okay, but then they still have to meet with these other providers that may not look like them. They're being rushed. They're not listening to me. And so we have, I connect at our agency, we make sure that all of our clients have case managers, again, that looks like them. So they have someone that can help advocate and maybe navigate some of these systems, because that it is very key. So I think as practice, I would say with some of us, with our Black in our therapy agencies, taking all that into consideration and understanding the power of that. But like the other flip side is getting more of us into these professions, because when we're talking about how we're impacted with diabetes and high blood pressure and all these different things, and then we can even track that back to dealing with racial trauma and all these different things, how that impacts us, it is imperative, and as an educator, moving into that direction of how can we get more of us into these fields where people can have that. My cardiologist, where I go, everybody wants to see him because it's not that many Black cardiologists. When you want to go see another Black doctor, there's another lady who's wonderful. All of us want to go and they don't have the capacity. And I know, I haven't spoken to them personally, but I know how it feels when I don't have the capacity to meet with everyone I want to. So that is something that I hope as a practice of just getting more of us to think big and see how we can get into these spaces, with healthcare and these treating the things that impact us the most.
Thank you. Just wanted to open it to Nicole in case you had anything to add.
Just all the things. This is all great, but my hope is that there would be better checks and balances within the medical profession. Because so many people have bad experience with medical professionals, but they know that they can't go anywhere. If they report it, they don't hear back. And so they just have to, flounder through the system, or hearsay, she say. And then they finally get to another person where it's like, okay, this one's a good one. And as we're all talking about, they all flock to this good Black medical professional, whether that be mental health or anything, and then they get full. And so everybody else is left out. So I wish there was just, again, I'm not in health administration, but I wish there was just a better, kind of governing of, if you're getting this many complaints, and you need to come in. because that is still a medical misconduct. So just like if you did something else bad and you got your license taken away, then that needs to be seriously reviewed. And I feel like that is where a lot of medical professionals are being able to slide along the racism line, where I'm still doing okay, nobody knows about it. And there needs to be more of those checks and balances, some anonymous tip where you can put in what's happening. And honestly, it should be like that with each appointment. If you go somewhere, they're always like, well, how did you feel about this? How was your visit? But it's usually not like that amongst medical professionals, which is interesting. So that is my big overall goal. And I really feel like that will push us forward to getting better treatment in our Black healthcare.
Yeah, I will say that, I mean, obviously, like, racism is not a generational thing. Racism is not dead by any stretch of the imagination. But I do think that, like, in medical education, there is more recently more focus on kind of cultural competency in the classroom, you know? I mean, so not the people who are necessarily practicing yet, and that's kind of part of the problem, kind of the older generation teaching us their ways, and then us having to, like, unlearn all the problematic things that they have done for decades and decades. But hopefully, you know, with time, that's a very unsatisfying solution, I guess. But I feel like things will hopefully, like, slowly get a little bit better as we incorporate microaggressions and implicit bias and cultural competency into the medical curriculum itself.
And I really appreciate, I mean, we're having such a conversation about medicine itself, and the AMA in the past couple of years, the American Medical Association has really started to not only take account for how they had a hand in dismantling the number of Black doctors and Black medical students that were trained through Black medical schools, but also in terms of facing that understanding that, okay, we are the American Medical Association, and public health really, really matters. And so we need to be thinking about the full holistic opportunities and communities. So whereas we need to see more clinicians, Black clinicians or clinicians of color, we also need to see more teachers. We need to see more restaurateurs. We need to see more civic leaders in our community, and how all of that, before we even get, right? Like before we even get to the cardiologist, which go Desmond, we were so excited that you're gonna be there. But before we even need to talk about the impact that it's having and the stress, the compounded stress that starts as early as when you are in your mother's womb and through that gestation period, how do we actually talk about creating, again, just these holistic communities? And if we know that a clinician who shares your same religion, who shares your same language, or who shares your same race, although socially constructed, if we know that that is all going to impact how you're able to adhere or able to hear them, then the same is true for what's happening in our classrooms, right? The same is going to be true. I mean, the amount of overwhelming support that Barack Obama received from the Black community, regardless, in some cases, of their political affiliation, because it was like, oh, I see you, you hear me. So we have gotten so far, and I think so grateful for the movements that have created integration in our country, absolutely, and how far we've come as a country, but how we must not become so colorblind that we don't think about how important it is to still see people in spaces and places.
Thank you all so much. This has been a really good conversation, and I know we're up on the time, but I wanted to kind of just let you express your final thoughts, and really this is one of my favorite questions to ask. But like Dr. Pryor said, this has been a conversation that has happened, and I'm sure will happen again, and will keep happening. So what's it going to take to stop having these same conversations and to really get to where you would like to be? I know I ended with like the toughest one, so I apologize, but whoever would like to go first.
I'm gonna just say what first came to mind, but it's believe Black people. That's the problem. When we say there's a problem, we get gaslighted. We get told that we're lying. No, you're just making it up. In every sense of the word, maternal health, they say I'm having chest pains. No, you're not. Next thing you know, they passed away. I'm having mental health issues. No, you're not. Next thing you know, they're just, anything can happen. So just getting to that point where we're being treated as humans. We're not, it's just that thing. Believe us. And that also goes with, the fact that we have more Black representation because we believe us. We believe our people, but other people do not believe our people. So that's what we're trying to get to, is believe Black people.
I participated in a conversation yesterday, a critical conversation about critical race theory. And one of the questions that I asked, because it was similar to this, what do we need to do? And some things coming back was, some people still feeling that CRT is damaging and divisive and it makes them uncomfortable. So my question was, well, what are you uncomfortable about? Why are you uncomfortable? I'm uncomfortable all the time, but I still got to show up and show out. And so I think for this, my response to this is the same thing. For change to happen, is you're going to be uncomfortable. And so for things to really move a little bit, folks need to be okay with, yes, power structures may change. A lot of things. And no one's saying nobody's trying to enslave somebody else or oppress you or that, or all the different boogeyman conversations. But for this to really happen, you really have to be okay with being uncomfortable and really wanting to, see change come about. So until then, I think that's just where we're at. You're gonna have to be uncomfortable, but we can move forward.
And Robin, I just wanted to say, I really agree with you. And, many individuals don't want to be uncomfortable. And I also think that anyone that is going into the helping profession or any profession, I think needs to be vetted more. I'm in the field of social work. That's what I do. And I've seen a lot of students. And, quite honestly, I've seen students that really didn't need to be in the profession. And I'm sure that all of us have had that experience. And so I think that we're going to have to be more strict when we're training people that are going to be providing services. And I also think that the history of what has happened in this country to Black people, as uncomfortable as it might be or is for some people, it needs to be talked about, accepted, and embraced. And there needs to be intentional strategies to get rid of it, by any means necessary. So thank you.
I guess for me, it's about creating the intentional collective spaces of hope for particular populations that have continuously felt the oppression and marginalization. And when I talk about that, I think about Black people who have been fighting for such a long time, Bailey. It's just, and it's now embedded into families and into genetic codes in terms of, I will keep pushing against these systems by myself. And those collectives, I think we need, as Black people, need to know when to rest and when to say, it is okay for me not to fight every single fight that's out there. And I think it's important for whiteness to be examined. Let's start talking about it and getting more comfortable with using even the term whiteness or white in this country. And let's examine what that means and how do you take up the mantle? And what do you do to fight for communities that have been continuously oppressed? We saw such a groundswell around the world in 2020 when George Floyd and Breonna Taylor were at the forefront of, this understanding of, with these triple pandemics that are happening against people of color in the US and the COVID-19 and economic oppression. And all of that groundswell quickly went away and reverted back to where it was before 2019 with people who were supporting movements around the world and Black Lives Matter. And so where is that? That is my call to action. If you are on and you don't have a collective space of hope and community to where you will know when to rest and someone else can tap in for you, and if you are particularly a person that has not ever examined the power and the legacy of oppression that has happened through your culture, through your history, through your family, then I would say have a call to action for yourself to say, what can you do about it? And for everyone, and this goes across the board, whoever you are, voting matters. I teach students about how to find everything from local governance, neighborhood associations, to what's happening on the world scene and how to get involved. And it's so difficult. It's so difficult. I had to actually walk through the other day of like, this is how we're going to do this, and so it's not an easy thing to do. We don't teach civic involvement and engagement in this country. And that's, I think, intentionally designed for us not to know. So find a way in the very smallest aspect of your community to get involved, and also find a way to rest.
Both important messages, definitely.
Yeah, I don't think I really have much to add, honestly. I mean, as it relates to racism in medicine and equity in medicine, like I said, I think increasing diversity in the field is paramount, and I think we need to maybe change how we approach that. We have these kind of high school to med school pipelines, and we have these kind of early acceptance programs through some HBCUs in the medical school. But I didn't decide that I wanted to be a doctor in high school. This has been like a lifelong fascination with STEM. So we really need to invest in our minority populations at elementary school. I mean, we need to get kids excited about STEM and keep them excited about STEM throughout their educational career in order to propel them into these spaces. As far as racism generally, like it's been said, we have to talk about it. Black history is American history, period. And maybe referring to it as Black history kind of others it for some people. And they feel like, oh, that's Black history, it has nothing to do with me. I remember a conversation I had with someone about Martin Luther King Day, and they were just being a little bit flippant about it. I was like, well, this isn't just a day for you to be off. This has significance to Black people for very obvious reasons. And therefore it should have significance to you as well, because as it is a part of my history, it is equally a part of your history. Your ancestors were marching alongside Martin Luther King or throwing things at him as he was marching. One of those two is true. So really kind of embracing all of our history and being, as Dr. Pryor said, being comfortable with having that conversation about race and the terrible, terrible things that have happened in this country is paramount. You cannot ignore the past and hope to heal in the future. That's just not going to happen.
Thank you all so much for being here and for going over the time a little bit. We appreciate this very rich conversation.
Thank you. Thank you, everyone. First of all, thank you to Bailey, our moderator, to our esteemed panel, to Dr. Campbell. We really sincerely appreciate you dedicating your evening to us for this important conversation. I'd really would sincerely like to thank the Fraser History Museum and the Courier Journal for your partnership on this wonderful series that we've had over the last several months. And to our community that is watching, I would really like to put a call to action out to you to communicate to the Ollie Center, to let us know what you'd like to see coming out of the center over the next year and beyond. What types of conversations can we host at the center? What type of programming? What does the community want to see of your center, of your Muhammad Ali Center? Easy way to reach out to us is just through education@olliecenter.org. That's an easy email, just education@olliecenter. Send us your thoughts, send us your ideas. We really want to hear from our community and make sure that we are serving our community in the best possible way that we can. Thank you all for being with us this evening. Be safe, be well, and have a great rest of your week. Thank you, everyone.